Striding with a population of about 34 million people, the health sector in Uganda is one of the most challenging, grappling, and yet tussling to take care of a high population growth rate and saving lives of mothers, children, and newborn day in and day out, especially from the vulnerable communities.
In Uganda, maternal, infant, and under 5 mortality rates are still too high. According to the Uganda Demographic Household Survey of 2011, maternal mortality ratio stands at 438 maternal deaths per 100,000 live births. Infant mortality stands at 54 deaths per 1,000 live births. Under 5 mortality stands at 90 deaths per 1,000 live births. MDG targets for Uganda stand at 131 per 100,000 maternal mortality ratio, 31 per 1,000 infant mortality, and 56 per 1,000 under 5 mortality.
At this rate, Uganda is unlikely to achieve the MDG targets for 2015. Ignorance, lack of health education, and sensitization of the importance of antenatal care to the expectant mothers while at the early pregnancy stage to prepare them, and failure to use health facilities for delivery has always been one of the daunting factors causing unexpected loss of lives of both mothers and infants. In many cases also, the mothers have turned their attention to the services of traditional birth attendants during delivery.
These women who are pregnant must go to the antenatal places for them to be checked to find out what progress they are doing. But still, I'm telling you, it is the attitude. And you know, to fight an attitude is not a very simple job. If you have done psychology, you know it very good. But if it is of an individual, maybe it is, but it becomes a communal attitude. It becomes very difficult.
Inadequate shelter, poor clothing, hunger and malnutrition, lack of safe water, poor sanitation, illiteracy are the most crucial issues affecting the health of mothers and children, let alone the biting economic hardships, poor family relations, domestic violence, coupled with transport constraints to health facilities.
It is one thing having the health units in place, but it's also another thing for the mothers to attend these health facilities. I will tell you about some cases whereby we have lost our mothers, pregnant mothers, because they delay to come to the health units of the hospital when it is time for delivery. You find that a mother, when she begins to feel the pain of delivering, that's when she remembers to move to the hospital. And this has cost us quite some lives of pregnant women, because some of them are made to walk long distances. But remember, you are walking, at the same time you are having pain.
Majority of expectant mothers in rural areas face a daunting task in accessing health facilities for both delivery and, as a consequence, traditional birth attendants are playing a significant role in delivering these mothers. In most cases, these are very unsafe deliveries with a high risk of children and mothers getting infected with HIV and AIDS. Raving in dilapidated infrastructure, poor facilities, lack of medicines, poor beddings, and lack of sufficient staff, health centers are loomed with the overwhelming number of patients, in and out every day, almost 24 hours a day. Sometimes, most of these expectant mothers take a day or two grappling with pain within the vicinities of the hospitals before seeing a doctor in these poorly facilitated hospitals. In most cases, complications arising from deliveries of mothers have been beyond the traditional birth attendant's limits to handle, putting both the newborn baby and the mother at the risk of either getting infected or losing life.
Now there is also the aspect of laxity. what I would call negligence by our health workers. Even when a mother reaches the health unit in time, at times you find the health workers are not there to attend to this woman in time. But also, even when they are there, there is some negative attitude. The woman has come, but they take time attending to her. And this has also made us lose some of our pregnant women. We have been encouraging parents that when a mother is pregnant and the time is due for delivery, let this woman move to the nearest health facility so that the health workers can take charge of the pregnant mother.
The other intervention that we have tried, of course, as a challenge, we do not have adequate human resource. According to the Ministry of Health structure, midwives are supposed to be up to the level of a health center, twos. But in this district, there is no health center which has a midwife. And even some of the health center threes do not have the midwife. There are areas where health services are not easily accessible. And eventually, that one makes the mother not to access our services. And in the end, we end up losing such mothers.
In Uganda, malnutrition is known to be one of the most underlying causes of child deaths. It accounts for 60% of child deaths, and there is a challenge of children having a balanced diet. The country still faces challenges like malnutrition, especially among mothers and children. In some families, lack of nutritional knowledge, such as food values and selling of most nutritious foods, has increasingly led to lack of a balanced diet for children and mothers.
We want them to value these natural foods. For example, you have granuts. It has a lot of food values. You sell granuts, then you go and buy meat. Are you thinking? We also tell you, even these greens, sometimes when people think they are not for greens, it is bad. So the first thing is to pass information and say, what food can we get nutrition from? Because the thinking of our people is that it must be meat.
Gaps in the unmet family planning needs of about 40% has greatly affected the survival of newborns and the well-being of mothers, causing an unprecedented increase in both infant and maternal mortality.
The World Vision has also helped us through practically showing these people what they do. If I told you like that thing we talked about when we were in Tubu, they were there explaining to the women how they can prepare good food for their children using the minimum resources. Because people think you must have money in order to have nutrition in the body. To me, that's not correct. It is only the techniques, how do you know. So we also give them the skills, and then we give them the demonstration.
Negative attitudes and commitment towards family planning, poor community sensitization, and nutrition, especially for expectant mothers, and poorly facilitated health centers and poor breastfeeding methods are stretching landmark problems, causing unprecedented number of deaths on mothers and newborn babies in Uganda today.
As people's representative, we speak out on what we see in the communities. For example, today we know that in Uganda, 16 women die every day in childbirth. And these 16 women who are dying every day are our constituents. The women we represent, the children, the newborn who die at birth or shortly before birth would be the citizens in our constituents. So these are the issues that our constituents expect us to talk about. Yes, the health system is there, but then when the drugs are not enough, when the midwives are not enough, when the remuneration of health workers is lacking, it makes it a bit dysfunctional.
But what measures is Parliament as well as government taking to avert the situation?
As members of Parliament, we made an undertaking that the 9th Parliament must make a commitment and a difference in the improvement of maternal health.
At the beginning of the millennium, the government embarked on radical measures following its commitment to the UN General Assembly to end infant and maternal mortality and improve the health sector. Government set up long-term commitments to improve the health sector, education, agriculture, rural infrastructure, and to promote safe water by 2015. 2 years to 2015, what is there to show government's progress?
Continued advocacy has led to slight improvement. Initially it was 8% of the budget. Somehow it went up to 11, then it went down, but we have intensified. For example, last year, we had a stalemate when we refused to pass the health budget until government made a provision to increase on the salaries of midwives.
A case in point, we find we are not supplied with maybe oxytocin, which is supposed to be used in maternity. So the mother comes, she delivers normally, but then after delivering normally, she overbreeds. So when the mother has overbred, you are here, you don't have something to, this is a health center through, you're supposed to admit people, but you don't have intravenous fluids, that is one. You don't have any drug, maybe oxytocin or misoprostol, where you can do what? Control the breeding. So at the end of the day, you risk the life of the mother.
We had made some improvement, though now we are stagnating, but MDG4 on child health and MDG5 on maternal health, those ones were not performing so well. We have made some improvement, but unfortunately, by 2015, which is just around the corner, we will not have achieved the target.
Through decentralization and empowering of the local people, government set up health centers from Health Center 1 to Health Center 4, aiming at improving the health condition of every Ugandan and to deal with the causes of infant and maternal mortality down to the local level.
We have a healthcare system which is kind of a referral system. So we have the Health Center 4, which is at a constituency level or a county level. Then after that we come to what we call the district hospital. So that what defeats the village comes to the parish. What defeats the parish, which is Health Center 2, comes to the sub-county, which is Health Center 3. What defeats them there? And the difference is in terms of, one, the infrastructure. In the village level, there's even no infrastructure. It is just people. At the Health Center 2, we have minimum infrastructure for OPD, outpatient department. They don't admit at that level. When we come to the Health Center 3s, we have some infrastructure for admission. One critical one is what we call the maternal ward, maternity ward, and the children's ward, which focuses on really our subject of discussion, so that we take care of them at that level. Then the same thing comes now to Health Center 4, where we now have more facilities and admissions of all categories, because now we have a medical doctor at this level.
Looking at the government program and its commitment to the UN call, the population seems to be still desperate and yawning. In the health centers, the level of staffing is way below the expected number required for sufficient services to offer. This has made a few come to terms with the challenges, working beyond their normal expected time and sometimes 24 hours.
You find you are working as an administrator, at the same time you are working as a medical person. So each and every report, each and every question concerning that unit, it goes to you. Like a case in point, every week you find like you have to submit in like something to do with 7 reports. At the end of the month, you have to submit in something to do with 10 reports. Quarterly, you have so many reports that you're supposed to submit in. So there you find like you're supposed to be at the table clerking patients. You're supposed to keep each and every record. You keep it and you are just alone. But according to the setup of a Health Center 3 in Uganda, you're supposed to at least have somebody to help you with records.
Civil Society Coalition on Maternal and Newborn Coalitions calls upon government to live up to its commitments made under the UN Global Strategy on Women and Children's Health by ensuring that The budget allocation for the health sector is increased to 15% of the national budget by 2015. Comprehensive emergency obstetric and newborn care (EMONC) services in hospitals increase from 70% to 100%, in health centers from 17% to 50%. Basic EMONC services are available in all health centers. Skilled human resources for health are available and facilitated in hard-to-reach or hard-to-serve areas. Reduction in the unmet need for family planning from 40% to 20%. Focused antenatal care increases from 42% to 75%, with special emphasis on the PMTCT and treatment of HIV. At least 80% of under 5 children with diarrhea, pneumonia, or malaria have access to treatment, oral rehydration salts, and zinc within 24 hours. Immunization coverage improves to 85%, and introduction of pneumococcal and human papilloma virus (HPV) vaccines, and provide more investment in scaling up nutrition.